Well, good afternoon and greetings, everybody. Welcome to Section 4 of the Lurie Children's Pediatric Surgery Roundtable Series. In this section, we will introduce you to APN Kate Chapman. She will be discussing gastrostomy tube management and modern management of gastrostomy tubes. My name is Chad Worley. I'm your moderator, and I'm the Lurie Children's Physician Liaison for the North Suburbs, the City North, and the City North. I'm joined by my liaison colleagues, Paula Nowak and Julie Kalkbrenner. Before we move on, I'd like to tell you a little bit about Kate and the wound, ostomy, and gastrostomy and tube care program. So, Kate Chapman is an advanced practice nurse with more than 9 years of experience in the field of pediatrics. She is certified in wound and ostomy care, specializing in the care of children with a variety of wounds, as well as ostomy, I'm sorry, I get that wrong, and gastrostomy care. She currently provides services to surgical and non-surgical patients in the inpatient and outpatient setting. Our tube care program at Lurie Children's has a team of advanced practice nurses, all certified in wound care. Since we have the largest pediatric focused wound care team in Illinois, we are able to provide timely and expert care to this special population of children. Team members are available for outpatient visits by appointment, as well as inpatient consults. You'll see the services provided there. Kate's going to talk a little bit more about that later in the program, as well as where we see patients and all of our providers. So I'm excited for her to talk about the program a little bit. But before I turn it over to Kate and take the screen over to Kate, I want to remind you all that the session is being recorded. And if you'd like to view it again, we'll send you a link. We'll also send links to your colleagues who are not able to join us today. And feel free to share those links with your colleagues who may enjoy this program. We encourage engagement. Engagement makes these programs fun. So go ahead and type in questions into the Q&A section. At the end of Kate's presentation, we will go ahead and ask the questions to Kate and she'll ask them. And depending on the size of our audience, we may ask some of the questions live and unmute you. So, but without further ado, I'd like to introduce you to Kate Chapman. Kate, thanks for being here today. And I'm going to stop sharing my screen and you can take over.
All right. Thanks so much, Chad.
You're welcome.
Bear with me. Going for you guys. Sorry, Chad.
That's okay. Take your time.
Practice it when it takes me a minute.
We've all been there.
Yeah.
Fantastic. All right.
Oh, still wants to go to the. All right, hold on. We just get us to the front. I apologize. So as Chad mentioned, I am Kate Chapman. I'm one of the nurse practitioners who works on the wound, ostomy, and gastrostomy team here at Lurie Children's. And today I'm going to talk a little bit about G-tubes. So gastrostomy tubes, or G-tube, GT, or buttons, as some families call them, they're a surgically placed device that are used to give us direct access to the stomach for supplemental feedings, hydration, or medications for some families, for some patients. They are placed for a variety of reasons. Not all patients are receiving feedings when they have a G-tube placed. Many of them have different conditions that require them to have the tube placed. For the tube placement, a laparoscopic camera is inserted through the umbilicus to visualize the stomach. It is then insufflated with air, either through an NG or an OG tube. Large sutures, as you can kind of see in the pictures, are placed under laparoscopic visualization through the abdominal wall, then through the stomach, and then back out the abdominal wall. They're then used to hold the stomach up against the abdominal wall. This small incision is then made at the site of the planned G-tube, and then the needle is inserted into the stomach, followed by a wire. They then dilate the tract over the wire, and eventually the G-tube is inserted, as you can see in the picture. A balloon is on the inside of the tube that sits inside the stomach that is inflated with water, and that helps to hold the tube into place. Sutures can be left in temporarily, as you see on the left-hand side, or they can be buried under the skin for more permanent support, as you can see in the right. So our general post-op management involves several things. The biggest thing is we want to make sure that this tube does not come out in the first 6 to 8 weeks. This is when we are seeing the most healing happen in that tract. We want that tract to have a chance to scar and fuse together. So the abdominal wall and the stomach are brought up together, and we need that to scar open to keep that tract stable. Sometimes we'll have families wrap their children's bellies with an elastic wrap for the first 2 weeks, especially with our busier children. Removing extension sets, which we'll talk a little bit more about after each use, is very important. And then we provide the first tube change in clinic at 3 months post-op. So this gives us a chance to check in on the family. It's usually the second time that we're seeing them post-op. We see them at 2 weeks post-op as well. And then every 3 to 4 months, we change the tubes, not because there's a risk of infection or anything like that, but the balloon on the inside of the stomach, it loses its integrity over time, and that's why we change the tubes. It really is a great opportunity for us as a team because we provide continuity of care for patients and families for the duration of the time that they have the tube. So there are some kids who have their tubes for just a short period of time, and there are other kids who have it for the rest of their life. We see infants to young adults, and one thing that we've noted that sometimes we do have patients who are a little bit older who are continuing to follow us into adulthood because there is a lack of gastrostomy care in the adult population in the same amount of support that we can provide on our team. So it does fall on us to continue to follow those patients, but it also is important and a great opportunity for you as providers in the community to also care for those patients and understand what the needs are with that tube. So some of the general care tips, like I said, that extension set is a separate set that is attached to the tube itself. We recommend that it always be removed after the tube is in use. This helps to prevent our accidental dislodgement and prevent irritation of the tract from pulling on the tube. We see this a lot more in our busier kids, but the whole goal is to avoid that tube being dislodged accidentally. Most kids don't have the strength to pull out that tube themselves. And so I educate families and providers that it's usually adult error if a tube is dislodged accidentally, especially in that first 3 months when they're getting used to using it and having it there. As providers, whenever possible, making sure that we order medications in a liquid form really helps out a lot. Some pills can be easily crushed and diluted in water, but some will clump together in the tube and they can clog it, which can cause all kinds of issues, especially if they are too early for us to change that tube because it's just been surgically placed. But so the one thing that I want to encourage all providers is that whenever you're caring for a patient who has a gastrostomy tube, please consider the route that they're having medications administered when you're ordering and managing their medications. For our postoperative patients, when it comes to bathing, they do have some slight restrictions. All children can take a regular shower or bath after 5 days. We just don't want it to be a prolonged submersion for the first 2 weeks. We want to give that tract and site a really good chance to heal properly. But most patients, unless they're having site issues, will be given clearances to submerge completely and even swim at 2 weeks post-op. At Lurie Children's, we currently carry 2 different brands of low-profile tubes, as you can see on the right-hand side. And we also carry long tubes, so long gastrostomy tubes that have an adjustable bumper that we can move up and down to give an appropriate fit for the patient. The extension set tubing is something that is connected either in the middle of the port or, as you can see on that long mic, there's a different kind of port that it goes into. And that allows us access to use the tube and administer what we need to. So The biggest thing is that we want to make sure that when they're not using the tube, that extension set is taken off, and then all you'll see is what those two low profile tubes look like at the skin level. Now I'm going to talk a little bit more about the common problems and their management, which I'm hoping will give you all a little bit more of some basic management and troubleshooting strategies, so that if you do have G-tube patients in your practice, you can help them to troubleshoot some of those concerns. As I said, we'll go through each one of these in a little bit more detail. The first problem that we see is skin irritation. So skin irritation can be caused by several things. Drainage from the site is actually quite normal. That first picture that you see on the top left-hand side, or the top left, is a normal post-op irritation that they can sometimes get. So the drainage from the site is normal. It can be yellow, it can be brown, and usually what will happen is it crusts and dries on the skin, and it can cause it to be a little bit irritated. So I like to compare that to if you had a runny nose and it dried on your skin, you would see that similar irritation. The difference is that you have this coming from a tract that is connected now to the stomach. Another issue with skin irritation can be from rubbing of the tube. Sometimes it's related to the fit of the tube. Sometimes it's just that it's a very busy child and they are moving around a ton. And so we can stabilize that tube a little bit to prevent that from causing an issue. The other thing that we also see is from excessive leakage. You can see the patient in the top right-hand side. She has had excessive leakage from that site. And so her skin is becoming very irritated, but you can see the spectrum is very mild to very severe, depending on the cause and duration of that skin irritation. Typical treatment for anybody who has skin irritation, we recommend starting with a topical barrier cream. Anything that has a zinc-based product that is very helpful to protect the skin and seal out any irritant that might come in contact with the skin, much like you would for a diapered child. We also use split gauze or a thin foam to absorb the drainage. But if it is getting worse, they may need some advanced wound care dressings. Sometimes we have to use Silvadene to help quiet down and treat it almost as a burn from gastric secretions. And then we have used fluticasone or Flonase, the topical steroid prick, as a topical steroid spray, which helps to quiet down that inflammation component of the irritation. So we often see something called hypergranulation tissue. So granulation tissue is a normal part of the healing process in our body. If you have a deeper wound, granulation tissue is a crucial part of that healing process. However, hypergranulation tissue is an overgrowth or overreaction to healing. So in the case of hypergranulation tissue at the gastrostomy tube site, it's believed to be the reaction to the tube being there, and the body is trying really hard to heal that tract. Eventually, it runs out of room in the tract, and then we see this lip of tissue that develops at the skin level. It can look kind of pink, pale pink or bright pink, and then usually I instruct families to tell me whether or not it looks like the inside of their cheek, because it does have kind of a similar mucosal appearance. Often it can happen in the first 3 months while that tract is initially healing and the body's getting used to being there. But sometimes we do see it occur if there's a poor fit or there's constant tract friction. So that tube is constantly moving or being rubbed against. Some patients will develop hypergranulation tissue when they're acutely ill, and that's because their body is believed to be in kind of an overdrive state where it's trying to heal other things and fight off the infection that's going on in their body, and sometimes it will react to that tube being there. Usually what families will report is an increase in drainage or a different type of drainage. So it is lovely that this tissue can produce green, yellow, brown, pink, or blood-tinged drainage, and it often has a mild odor. It can be a little bit of a thicker drainage or discharge. So families will often, or providers will often call us and say that they believe that there is an infection because there's pus, and this green drainage, but it actually is just from the hypergranulation tissue. It's not infection. The tissue itself is not infectious or caused by an infection. It's a reactive overreaction to the tube being there. And we'll talk a little bit more on how to treat. So management of hypergranulation tissue, our first line is we will start with a topical steroid called triamcinolone cream, the 0.5% 3 times a day for 2 weeks. It is much more responsive to smaller amounts of hypergranulation tissue. You can see kind of the in the pictures how minimal it can be and how extreme it can become. We also will recommend tube stabilization. So if we have a very busy child, we will have them wrap up their belly with that elastic wrap like I talked about before, or just having different securing clothing options, onesies when appropriate. And if we can, if it's appropriate for the patient, we'll resize the tube length and fit, which I'll talk a little bit more about too. If there's a significant amount of the hypergranulation tissue or we're not seeing any improvements or minimal improvements with the more conservative treatment, we do recommend applying silver nitrate to the tissue. However, when we apply it, there are specific things that we have to follow. So a barrier cream must be applied to the skin prior to application, as it can cause staining of the skin if we don't do so. And then some patients do report that it is painful to apply, which is why we like to start with the more conservative approach first. It does often require multiple applications, and then once that tissue that has been chemically cauterized by the silver nitrate sloughs off, then they resume the steroid cream. So it kind of reboots that process so that we can more effectively treat it. If we get into a situation where we're unable to have it go away, unable to help it go away and treat it with topical options, then surgical excision is required and recommended for patients. As you can see, the patient on the the bottom picture on the right, they needed a surgical excision of that tissue because we were not able to adequately treat that in clinic. So the other thing that we see sometimes, not many patients get this, but it does happen, is gastric mucosa or prolapse of the mucosal tissue at the site. So typical causes of this are excessive tension or pressure pulling on the tube. The mucosal tissue is actually pulled upward into the tract from that tension. This tissue will not respond to triamcinolone cream or silver nitrate. The best thing that we can do when it is minor is to protect the surrounding skin from the drainage. The difference in the drainage between hypergranulation tissue and gastric mucosal tissue is that the mucosal tissue won't necessarily have all those colors of drainage. You won't see green, thick, white, brown, or the bloody drainage all that often. It won't have that same similar odor that we sometimes see with the hypergranulation tissue. And then, like I said, it won't respond to your triamcinolone cream. It does have more of a smooth appearance versus the hypergranulation tissue and how it can look almost more of a cauliflower texture at times. So we protect the surrounding skin from our drainage. We're also going to stabilize the tube to try and prevent it from turning into something more severe that requires a surgical revision. Surgical revision is recommended if there's prolonged skin issues, if there's ongoing leakage and they're not gaining weight due to the loss of formula from the site, or if it is as extreme as you see in that one picture where that patient's gastric mucosal tissue is actually losing blood supply and needs to be urgently repaired. That is not a common thing that we see. Candidiasis, it can also occur at the tubes and is something that you may see in your practice, caused by excessive moisture that gets trapped underneath the tube. Oftentimes we'll see that this occurs when patients have deeper abdominal folds or a crease right where their G-tube is, or with a snug fitting tube. So we want to make sure that we get them the appropriate length tube and make sure that we're not sitting in that crease. Our typical treatment with this is nystatin powder or cream, and then using a foam or a gauze dressing to absorb the drainage to help protect that skin. When appropriate, we can measure and exchange the tube to make sure that the fit is not the contributing factor for the development of candidiasis. Because it's not that It's not that it's just snug. It's usually a combination of it being snug, plus you have the moisture that's getting trapped in there. And then the Candida that is normally a part of our skin flora just thrives in that environment. You may see kind of a brighter red, shiny appearance to their skin, or you may see some flaking or even the satellite lesions that are just more stereotypical of seeing a candidal infection. If a patient has a more widespread infection, so when I have patients who come in with an overgrowth of yeast on their skin at their G-tube site, I'm checking all their other skin folds. So if they're diapered, I'm checking their diapered area. If they have rolls, I'm checking their rolls. Oftentimes, if it's in one area, it will be in multiple areas, or if it's a significant amount, we will recommend doing an oral diflucan. However, there are some patients where it's contraindicated for them to use that. Some of our cardiac patients and other patients who are on certain medications, there's a contraindication. So we are mindful of that when we do decide to prescribe that or recommend it. Cellulitis is not a common thing that we see with gastrostomy tubes, but it can occur. The soft tissue infection around the site, surrounding tissues, and sometimes it can occur from a stitch abscess as well, where we'll just see kind of a pinpoint area where, as if you may remember from the beginning slides, that some surgeons do bury sutures underneath the skin, and the stitch can cause a little bit of an irritation that then comes to the surface. Typically what we'll see is that there'll be kind of a bright red streakiness around the tube, as you can see more so in the left-hand side picture. That's more common of what we'll see. It'll look a little bit more swollen. Patients will be complaining of tenderness, or for the nonverbal patient, they just won't want their parents going near it, and something just seems a little bit off. Obviously, the picture on the right-hand side is a lot easier to diagnose as a cellulitis, but you can see the two extremes there. We treat this with a systemic antibiotic, which is we typically use clindamycin or Cuflex, and that's based on the infectious disease guidelines for soft tissue infections for a non-complicated, non-open and draining wound. If we're concerned that it is more extensive, they may need an ultrasound of the area. If it is draining, it can be cultured, though often it gets contaminated with natural skin flora. So making sure that we're culturing just the appropriate, drainage that's coming from that site. And then if it's very severe, sometimes our surgeons will perform an IND. For patients who have gastrostomy tubes who are immunocompromised, they may not have any outward signs of infection that we would normally see in either one of these pictures above. So those patients may just start complaining of increased tenderness, sensitivity. There might be a little bit of swelling, and we typically err on the side of caution, and we will treat them for a cellulitis, especially if their counts are low, because their bodies, like I said, are not responding and reacting in that same way that we would expect a patient who is not immunocompromised. And then I'm going to spend a little bit more time talking about leakage, because this is a problem that we deal with a lot. Leakage of formula is often caused by feeding intolerance. So if there is a patient who's being fed through their gastrostomy and they are leaking their formula from the site, they're not tolerating that formula for one of several reasons. So feedings may be given or increased too rapidly for the stomach to tolerate. One thing that we need to take into account and explain to families is that when the gastrostomy tube is placed, the anatomy and positioning of the stomach changes. So sometimes feeding into the stomach, it's not able to expand, and they're not able to tolerate it as they did prior to having that shift in their stomach, bringing it up to the abdominal wall. Often during an acute illness, patients will have increased feeding intolerance or leakage due to GI tract function or dysfunction. So if you think about the last time that you were ill or caring for a non-G-tube fed patient, when they had a viral illness, we eat less. Our stomach doesn't feel good and things move a lot slower. So we take that into account with patients with G-tubes as well. And then with constipation, the stool burden can cause too much pressure on the stomach where it can't expand, and then it's going to leak out of the site. So I like to think of the G-tube as a pop-off valve. So it takes a lot more effort for a patient to vomit up their feeding after they've been fed than it would for it to just kind of come out and leak from this pop-off valve that they now have on their stomach, especially if they're really full or fighting an acute illness as well. Leakage is not typically a mechanical problem with the tube itself, although that is usually where we start our troubleshooting course. We usually very quickly determine that it's caused by something else. And so our top 3 questions that we'll ask families when they are experiencing increased leakage or feeding intolerance is, have we made changes to the feedings? Are we acutely ill? When was the last time they pooped? Because those are usually where we'll find an answer that kind of leads us to a solution. And this just breaks down the management of leakage. So mechanical problem, it's fairly simple. We check the tube length, we check that water in the balloon to make sure it has the appropriate volume, if appropriate, if it's been long enough since placement. And then we'll change an older defective tube if there is a perceived issue with it, or if the balloon is simply if it has popped or is no longer able to hold water because it's been in for too long. We recommend stabilizing the tube and using a barrier cream to protect the skin. So with any of these reasons or causes of leakage, the first line that we're going to recommend for any patient who has leakage is to use that barrier cream to protect the skin, because we don't want them to get into a situation where their skin breaks down to a point, as you saw in some of those skin irritation pictures in the beginning. For an acute illness, we recommend slowing down the rate of the feedings. Really, you can do that with any of these, any of the causes of leakage. You can slow down the feeding rate. Try holding feedings or trial a Pediatric instead. And then we're watching them closely for signs of dehydration, obviously, and then slowly resuming feeds when we can. But as I said, if you think about the last time that you were ill and had an acute viral illness or any sort of GI bug, your stomach didn't want to accept that normal amount of food that you had been eating when you were healthy. So kids with gastrostomy tubes, trying to give them sometimes a 240 ml bolus of their formula run at a rate of 30 minutes or over an hour. If you think about trying to do that when you're not feeling so well, it doesn't sound so great for me either. Constipation, we want to make sure we're addressing address constipation. We want to clean them out if they need it. They may need to clean out and then a maintenance regimen. So that is actually a great plug for our bowel management team as well, because they do help to manage a lot of patients who are having issues with constipation. And then tagging in our dietitians or making formula adjustments or nutritional adjustments to help them to move things more quickly, adding fiber, removing fiber, those types of things. Changing our volume and rate of or calories of feedings also helps. So slowing down the rate, as I said, there's nothing wrong with slowing down the rate of feedings until there's no leakage. Sometimes that does mean continuous, which scares people to have kids attached all the time, but sometimes their tummies just need it, and that's okay. We can decrease the volume, try to condense our calories as needed. And then if, as I said above, with constipation, also talking to a dietitian to see if there's adjustments that we can make. There's lots of other formulas that are available now on the market that might work better with a patient's stomach than the one they're currently on if they're having an issue with ongoing leakage. The other thing that we can do that we teach families how to do is vent the tube. So it's kind of an interesting technique where we have our extension sets and then we remove a plunger out of a syringe, attach it to the end of it and clamp. And then if there is a lot of gas in there, it will release that excess air. And they can do that before or after feeds, or if their child has been crying for a long time or seems really uncomfortable. It gives them a little bit of an extra tool in their toolbox to try and help troubleshoot at home. So for long-term problems with leakage, we do consider GJ tube placement and GI consultation just to make sure that there's not some other mechanism at play here so that we're not missing something or missing an opportunity to treat effectively. What is not recommended is trying to increase the diameter of a tube to stop leakage. What will happen is that you will plug the hole temporarily, but then you will just give that formula a larger tract for it to leak out of, because we're not fixing the underlying reason for that leakage. We also don't recommend bolstering with multiple layers of dressings underneath. As you saw on that, the page with the slide with the gastric mucosal prolapse, we can actually cause that to happen because you're pulling tension on the stomach. That balloon that's on the inside of the stomach can actually pull up into the tract and cause either mucosal prolapse or in extreme cases, we've actually seen the balloon erode all the way through the tract, which is a much bigger issue. We also don't recommend overinflation of the balloon to try and stop leakage. And the reason is the same as above. We just don't want to put too much tension on the stomach, on the inside lining of the stomach. And, if you keep inflating that balloon, then eventually in these really small bellies, you're going to run out of room in that belly. I've had a couple of patients where home nursing or someone in community recommended that they continue to increase the water in the balloon, and they couldn't tolerate their feeds, and they came in and had 15 mLs of water in their balloon, and it's only supposed to have 5. So we very quickly figured out that that was the contributing factor, but something that we recommend not being done. Tube dislodgement is the one true emergency with the tubes. The tube should be replaced as soon as possible to prevent tract closure. It can start to close down in 1 to 6 hours, depending on the patient. If it's dislodged within the first 3 months, pediatric surgery teams are available, and we would recommend them coming in to have it replaced by us or another trained professional near them if they live very far away from the hospital. If it's dislodged after the first tube change when they've learned how to do it, they may replace it at home, or it can be replaced by someone who is trained. They can also reinsert the tube, even if like the balloon were broken, they could reinsert the same tube, secure it down until we're able to get another tube open. But the goal is having something be able to be placed in there so that that tract does not have a chance to completely close. If we can't get something back in the tract, it does require slow dilation up, which patients don't enjoy, we don't enjoy, and families don't particularly love experiencing either. So we try to get something in as quick as we can. The dislodgement of the tube may cause disruption of the stomach from the abdominal wall. So remember, those 2 layers of tissue need time to heal and fuse together. If too much force is used to replace the tube, or it came out with a lot of force, then we would want to make sure that with a x-ray of the site, the contrast study, to make sure that it's still placed appropriately and safe to use. So this is one of my favorite patients who actually no longer had the G-tube. It was a really happy and sad day for me. But the steps for the G-tube placement, there's only 4 steps. I find that when I break it down that way, it doesn't seem so bad. We can all do 4 things. So the steps are actually very similar to each other. So we're taking our water out of the old balloon, taking our old tube out, putting in our new tube, and then reinflating with the correct amount of water. So I always tell parents and providers that it's water out, tube in, water in, and it makes it pretty easy. See if my video works today.
All right, now stop our tube just like always, okay? All right, wrap it up. First, we take out our water, right? And collect a little, take it out. Then we take out our tube. And that's the part, did it? So we flatten our hand. Balance. You're still good.
So you can see it's pretty easy. It truly only takes a few seconds to change the tube, but it's, it's a service that we provide for families. Sometimes they can't get the supplies at home because of their insurance. Families who are only using them for medications or hydration, or are no longer using it anymore, it was just for supplementation. Insurance companies will stop covering their supplies, and so they're required to come see us to have their tubes changed every 3 to 4 months. And sometimes we can extend that a little bit to help them out. All patients are established with a DME prior to discharge so that they have all their supply orders initially started, and then they receive them prior to going home. We typically send them home with extra so that they don't run into situations where they don't have supplies at home. And then the gastrostomy tubes and related supplies are usually ordered by our team. So the wound ostomy gastrostomy team, we see them every 3 to 4 months for their tube changes. And then if they're changing them at home, we see them yearly, and then we'll renew their orders annually. The primary care provider role is really important because many of these patients are not being followed by a dietitian. So the formula orders do come from you in the community, and you're typically monitoring their weights a lot closer and making changes to their formula and nutrition as needed. But our dietitians are always available, and we have a wonderful dietitian who works with us in pediatric surgery and sees a lot of our patients and helps us make different changes. So you may work alongside her, or she may recommend different things based on what the patient's weight looks like when we see them if we have concerns. The last piece is that once we reach that happy day where they no longer need their tube for anything anymore, we request that you work with us to give clearance for that tube removal. And that's something that we discuss with families kind of as we get closer, and things that we'll include in our notes so that you can be aware that we're kind of reaching that. And here are our locations that we service patients. So we're at the downtown location, and then we also go to 5 different satellites. I'm sure Chad will have me go through this a little bit more for you all as well, but we do have clinics pretty much every day of the week. And then one of our providers actually has downtown clinic on a couple Saturdays a month, which is wonderful for families as well. And this is something that you guys may have seen the screen before during other presentations. I've highlighted in blue the nurse practitioners who are part of our wound, ostomy, and gastrostomy team. And you can see there are 7 of us, and then we have a dedicated RN as well for support. And that's it.
That was great. Yeah, thank you for the wonderful presentation. I had a laugh at the Ice Age video. I mean, I felt like that describes my life sometimes. So, but the holes popping up everywhere and not know where to clog them next. It was really a great reference. So that was fun.
At home, so it feels like that all the time.
Right. So we got some questions coming in, and so I'm going to get right to it, and then I'm going to ask you some questions about referrals. So Dr. Freed writes, what do you do if the balloon ruptures or there is another malfunction of the tube and the insurance says it is too soon to authorize a new tube?
Right, that's a great question. So the first part of that is, so I typically, when we send our orders, we try to request an emergency backup tube so that hopefully we won't get into that situation. However, if it happens and it's the balloon that ruptures, remember that balloon is just the placeholder. So that's just what's holding the tube on the inside of the stomach. So oftentimes what we'll say is we'll have parents reinsert the tube. Sometimes they even just have to they can pull off the ruptured balloon, reinsert the tube, and then they can secure it down either with Tegaderm or another form of bandage to keep it in place until we can exchange it. And then we typically try to see those patients to replace their tube rather quickly. Any tube that is dislodged, we consider that an emergency. And so we add kids in same day. If it's broken, we will send them to a satellite. And then if there's, for some reason, we can't service them that exact day, or they live really far away, we have them go to their closest emergency room to have it replaced. Typically, if we are replacing it in a situation where it is a mechanical malfunction of the tube, I haven't heard of patients running into issues with that being covered because it's kind of outside of the bounds of what would normally be expected for the tube replacement. Hopefully that
Hey, along those lines, if something like this does happen and they go into their PCP's office, is there a good way for someone to get a hold of you or someone on their team? Should they go through Epic or direct message, or is this, or is this just send them to the ER?
No, so I mean, we try really hard to keep patients out of the emergency room. We educate families on that in the beginning when they're first getting their G-tube education like 1 day post-op for emergency care. So we recommend reach out. If you call our division and you say, I have a patient who has a G-tube out, they page us. It's like I said, we triage things throughout the day, but that is one thing that is an urgent message. It gets triaged immediately to us. And then we do also we carry around a Volt phone, which is a phone system that we have here in the hospital. And so people can get a hold of us rather quickly. If there were a situation where you needed to talk to somebody immediately, they can sometimes connect you to our phone, or they'll, like I said, they'll page us or they'll come find one of us and we'll be able to answer and help triage that right away. But our goal is always to try and keep kids out of the emergency room if we can. If you do have a patient who presents to your clinic, your office with a dislodged tube, but they have the tube, trying to insert the same tube back in. Like I said, you can even cut off or rip off a dislodged or a broken balloon if that was part of the issue.
Mhm.
But we teach families too who used to have like NG tubes that they could even just put an NG tube in there. So something to keep that tract open. If you have Foley catheters in your clinic setting and it's an established tube, or straight cathing supplies, like anything that is at least, a large enough diameter to keep something in there, and then taping it down until they can come see us to have it replaced.
In our would telemedicine visits on something like this be appropriate as well with you, or do you do those?
We do telemedicine visits. When it comes to like a dislodged tube, if the family isn't comfortable replacing it, we have them come in
Okay.
rather quickly to have that replaced. I do have some families who have just wanted somebody to kind of hold their hand over the phone while they change the tube over the phone. And so do that as well, either through telemed or just, sitting there on speakerphone and talking them through it.
Okay, great. All right. And I know we're running pretty long on time, so I got 2 questions up for you. Is there
Okay.
collaboration with dietitian in the G-tube clinic?
Yes. So Natalie Novak is our dietitian who works in pediatric surgery with us, and she is fantastic. Shameless plug for her, but she has patients who she follows along with long-term, or if there are patients that I'm concerned about or anyone on our team is concerned about, we let her know or give her a heads up. And so she follows up either when they come in for clinic, she'll check in on their weights and check in on how they're doing with their nutrition, adjust what she needs to with their feedings. And then if she's not able to see a patient with us in clinic or we're at a satellite location, we just reach out to her, and then she will actually call that family and then troubleshoot and go through it that way. And then she does a lot of telemedicine visits as well. So she does a lot of outreach and has been a real asset to our team.
Okay. And then do you have any suggestions for managing odor?
So usually if there's odor, oftentimes there's some granulation tissue there. There could be a component of you may want to consider like acid suppression too, if it's from leakage, like that kind of leakage from the site. But most of the G-tubes don't smell all that much, unless there's hypergranulation tissue there, if there's a yeast overgrowth on their skin, or if they have kind of like a chronic leakage problem. But typically we just recommend that families bathe their children, and then making sure that if they're a little bit squeamish about cleaning it, they can always use a Q-tip and just get underneath there to really clean that site. Because sometimes it's just a buildup of that excessive drainage over time that can kind of give it a little bit of a funk.
Sure. So there's, like I said, we're running out of time here. So, but I know folks on the line and who will be watching this recording are going to still have lots of questions for you. So what I encourage you all to do who are watching this session is reach out to your liaison if you want to set up a meeting or an appointment with Kate or other members of the team, so you can ask additional questions, or if you kind of want to get to know them more, we'd be happy to set up either a virtual meeting or some kind of in-person visit if that's possible. So Kate, I'd like to thank you for presenting to us today. This was a great presentation. And I want to thank you all for joining us as well, who's in the audience. And please join us tomorrow morning at 7:30 as we will introduce you to our intern division head of pediatric surgery and director for surgical oncology, Dr. Timothy Lautz, as he will be discussing when, where, and how hernias should be fixed. So until then, have a great afternoon, and we will see you all tomorrow. Have a great day.